I didn't check the percentage of questions that are on hematology or oncology. It's probably one question. So just take a guess and you'll probably do fine. But if it's just pure knowledge that you're here for, that's a different story. This was covered by Stuart. This is such a great fodder for questions, however. Absolutely. Carbon monoxide basically likes to go better than hemoglobin. Blood gases, we only measure, blood gases measure what's in the liquid component of blood. It's the liquid, it's got nothing to do with the cells. So the blood gases can be perfectly normal and the hemoglobin can be totally tied up with carbon monoxide or totally screwed up because of methemoglobinemia or some other reason. The blood gases are normal because that's what's in the dissolved part of blood. And we make some extrapolations from that. It just so happens that carbon monoxide kind of looks like blood to your pulse ox machine and those kinds of things. And remember the biz-buzz, right to left shunt, and hemoglobin problems are those oxygenation issues that are not solved by giving supplemental oxygen. This thing is all about oxidizing hemoglobin, oxidizers, whole bunch of oxidizers. They're talking about, and look at these, the shoes. We got the sulfur from the bladder infection. We got the pyridium for the bladder infection. We got the nitrates from the hot dogs. We got the lidocaine from really a bunch of common stuff. And if you get enough of that, there's lots of case reports of little kids who had some sore throat issues, and they did the benzocaine things, and they report these kids got methemoglobinemia just from squirting in the benzocaine into the back of their throats. Peter did a very nice explanation about this idea about it's hard to make an anemic person jaundice because they can't get this amount of the saturated hemoglobin. It's easy to make a polycythemic person, not jaundice, but cyanotic. And this was all covered in detail in the tox parts. Here's a little something, pack red cells. You have a donor, spin it down, take off the liquid component, stick it in a refrigerator. Its life in the refrigerator is 42 days. What keeps it alive during that time? Citrate, phosphate, dextrase. Citrate is chelates calcium. When we get into the clotting cascade, you'll see calciums all over the clotting cascade. If you take calcium out of action by citrating it, binding it, then blood won't coagulate. Phosphate is for ATP. Dextrose is the red cell fuel. It is all the brain fuel. And it's interesting, what is dextrose versus glucose? Glucose is a levo L and D isomer. The only biologically active isomer is the D isomer. So glucose is dextrose. Universal donor, O, donor, it's got O in it. Donor, blood type O, that's for donor. How much blood do you have? 70 per kilo. So the normal bear, 50, 70 kilogram, that's probably a woman. This is 5 liters. A 220-pound male is 7 liters. If you give somebody 1 unit of packed cells, you can expect their hemoglobin to go up 1.5. That's the ballpark. After 5 days, the platelets in a bag of blood are dead. And because you took off all the liquid component and put that and froze that, that's where all the clotting factors are. So bottom line is you keep on giving packed cells, and if you're giving a lot of it, basically you will wind up with a dilutional coagulopathy because you're giving all of these cells, but you're not giving anything that we need to make clots. So no platelets, they're dead, and you took off the liquid component. That's where the clotting factors are. Why do we use packed cells over whole blood? Well, if you give packed cells, you're giving more red cells per unit time and per unit volume, so that's really what we want to give is the red cells. We don't necessarily want to give. The idea is this person needs red cells. That's the oxygen transferring element. The vast majority of the oxygenation of tissues is done by the transfer of hemoglobin from red cells to the tissues. It's not about what's dissolved. So it's kind of interesting. You have an O2 we give oxygen to virtually everybody who comes in the emergency department. Sprained ankle, put oxygen on them, kind of thing. That will do virtually no good, because if your saturation is already 98%, if you put more dissolved oxygen into the liquid component is responsible for 5, 10, 15% at most of tissue oxygenation. It's all about hemoglobin and saturating hemoglobin. So you give out less volume. You get the stuff in the top there, although it has the clotting factors, also has a lot of protein antigens, which increases the likelihood for transfusion-related reactions. Citrate, the citrate's is in the liquid component. You give enough whole blood, you basically give them lots of citrate. The next thing you know, you are chelating your own calcium, and that's manifested in terms of QT prolongation and large volume transfusions. And because we need calcium for muscle contractions, there have been reported cases where large volume transfusions in otherwise well young people have been associated with little development of congestive failure, because the pumping power of the heart isn't compromised, because you have made that person functionally hypocalcemic because you gave all that citrate. Potassium, red cell, stored blood is hyperkalemic. The red cell over time breaks. You got all this debris that's forming at the bottom of the bag at the end of 42 days. There's 30 times more potassium inside the cell than out. So you break all these cells, and all of this liquid now becomes hyperkalemic. They say the only diluent for red cells is saline, and the idea was if you used Ringer's lactate, which had a little calcium in it, that this calcium and the citrate would neutralize each other. Next thing you know, you have little microaggregates forming. And you don't want microaggregates. They get showered into the pulmonary capillary bed during the trauma patient, making them more prone to ARDS. And you don't need those clots showered all over the place. The fact is that Ringer's lactate and blood, which is often used by surgeons, the more recent literature said, well, to tell you the truth, it's okay. Massive blood transfusions, by definition, are a total exchange of blood in 24 hours. So if you're a 5 liters person, then you get 5 liters of blood in 24 hours, is defined as massive transfusion. We are not interested in what happens in 24 hours. We're interested in what happens in the first hour or two when the person is there in the department, where we're aggressively giving blood in a small subset of people. Remember this idea about dilutional coagulopathy. So there's this idea that, well, let's just reconstitute whole blood. Let's give platelets, let's give phosphorescent plasma, and let's give packed cells, and then we'll give it 1-to-1 ratio, and we'll make whole blood again. And it'll clot, and everything will be great. So people have started doing that. The evidence for it is really plus minus, but because it's so physiologically compelling to make that argument, people tend to do it. But when you really look at the case for it in terms of outcome measures, it's really kind of iffy at best. So this is about the use of fixed ratios. One of the other reasons here is you're giving blood, a lot of blood quickly. Well, we know about this dilutional coagulopathy, so people say, okay, fine, we'll measure the proton and PTT and measure the platelet count, and if it's abnormal, we'll fix it. We'll give platelets. But by the time you know the answer, they've already gotten another 2 units of blood that made it. So the number is like a moving target. So the idea is, instead of having to worry about that, we're just going to give 1-1-1 ratio, and we're going to reconstitute whole blood. Hypothermia, that stuff has been sitting in a refrigerator. You're giving large volume of it, so the issue is that might make the patient a little cold. So you heat it up in those little coil jobs, but you don't get something for nothing, because when you do that, you make more microaggregates when you heat up the blood. So that's not a good thing either. The hospitals now are always using 40-micron filters. The filter that comes with the blood set is like a 200-micron filter, which stops basically nothing. So a 40-micron filter is trying to catch some of this junk that's at the bottom of the bag of blood, these clumped white cells and dead white red cells, and the skins of these red cells and all that stuff, which doesn't going to do you any good. So you put a 40-micron filter. Remember, a red cell is 7 microns wide, so six red cells can go through this filter holding hands and still not have a problem. It will slow down rapid infusion, so you might opt out to pass on the filter if the person's really needing it badly. So that's the micro aggregate issue. Citrate toxicity, we talked about that. And you got to basically know that QT prolongation is one of them, is a low calcium, short QT, high calcium. Blood transfusion reactions, this is the one that we're concerned about. This is giving the wrong blood type. This is a person B and you give them A blood. You know, we weren't supposed to do that. It's a wonder how this could possibly happen. You know, with all of the nursing procedures that they have now to prevent this error, it's like it still occurs. And I saw a couple nights ago, the missile silos in Kansas, you know, down there, where they still have people manning those things 24 hours a day with all of these drills that they go through. And it was really kind of interesting about the fact that they always have 2 officers on duty down there, never one. And when they get the code from the president to say, okay, let's go here, there are, oh, geez. How do I stop that? Never mind. Hold on there. I'm sorry. So the idea is that there's 2 officers to trigger the missiles. So they showed they had 2 padlocks. Each of them has a digital, each officer knows the number for his padlock. That opens a little box that has a key in there. And they put the key into 2 things that they turn. But the things are far enough away that one person cannot reach both keys. It requires 2 people, one person to turn that key and one person to turn this key, so that you can't have one rogue person setting off an atomic missile. You need 2 rogue persons. The immediate transfusion reaction is basically manifested by immunologic war. Preformed antibodies recognize that this is not the right blood type, attack these cells, surround these cells with IgG antibodies, destroying these cells. So there is a test that we do to see whether there's antibodies attacking cells called the Coombs test. And that basically says, yes, there are antibodies around the cell destroying it, or no, there are not. And these are preformed. They're already, I don't know who made them, but they're ready to go. And so they're destroying these red cells of the invader. Immunological war, so there's fever that's going on, chills, and that's one of the first signs of a transfusion reaction that may be going wrong. Why they have back pain, I'm not sure. Why they're breathless? Well, they're basically taking all of these red cells, killing the wrapper, and all of now free hemoglobin is all going, which is large molecules clogging up the kidneys, clogging up the pulmonary capillary bed, those kinds of things. So that's why we're talking about ATN and respiratory failure. Why you get bleeding, I don't know. Why you get hypotension? Well, this is an immunologic war kind of thing, and that's not unusual in the setting of an immunologic process going on with fever and chills. So what we do is we stop the transfusion, we hydrate to try to dilute down all of this free hemoglobin that's clogging up the pulmonary and kidney beds, and we send the blood to the lab. And we look for Coombs test, and we look for free hemoglobin. Free hemoglobin, there's a test called haptoglobin. Haptoglobin hooks up to free hemoglobin. So if you have a haptoglobin and hemoglobin forming, then the blood level of haptoglobin goes down. That is indication of free hemoglobin. Also, free hemoglobin will turn your urine pink. That would be an indication that you have an issue. And one of the ways that you know you have free hemoglobin is if you were to look in a microscope, you wouldn't see any red cells. This is all about free hemoglobin. So not like, we'd see with a kidney stone. So those are the tests that we would do. And if in fact it comes back that these, yes, you are lysing red cells, you did make a big mistake here, then the idea is to try to dilute down, give as much fluids as they're going to tolerate, try to ride out this reaction. The febrile non-hemolytic transfusion reactions are, for all the world, start out like the bad ones. But this is about protein antigens in the liquid component of blood. So there might be some fever and chills, but you send the blood to the lab, and it doesn't show that there's any hemolysis of blood going on. So this is a non-hemolytic transfusion reaction. You have to stop the transfusion and run these tests to see, because it's all the world looks like it may be that. Allergic reaction, you've heard of these. You pop a hive here. They can vary from a little redness and itching kind of thing to hives all over the place. One of the things that's kind of unique about this is that the amount of blood that you give does not determine how bad this reaction is, which is kind of weird. Usually the amount of antigen that you present to the person, the more the reaction is going to be bad. This is not like that. So if you need to give this unit of blood, and it's the only one in town kind of thing, if you basically give them antihistamines and some steroids and try to kind of suppress allergic type reactions, you can continue to give this blood if need be, because the magnitude of the reaction is not related to the amount of blood it's given, which is kind of unique. Here's the infections that you can get from blood. So if you add them up, all of the things that you could get in the way of bugs and viruses and bacteria, it's something in the neighborhood of 1 in 500. The risk of getting these more serious diseases gets lower and lower and lower. The risk of hepatitis B is now between 200,000 and 500,000. I'll take those odds. And hepatitis C and HIV is in the neighborhood of 1 in 2 million. 2 million units of blood, 1 HIV. And as the tests get better, I'm sure that number gets better. Transfer of viruses, they haven't been able to show that that really happens. While it's strange, because if they can't transfer viruses, but you can transfer chlamydia, that's kind of like, well, I don't understand that. Delayed hemolytic transfusion reaction, this is what you would expect. Normally, when you give an antigen, it takes 7 to 10 days to develop the antibodies. And so when you give your first dose of penicillin, you don't react to that. You react to the second dose. Or if you gave a penicillin or taken for 10 days and the rash starts coming out at the end there, not right at day 1, because it takes some time to make antibodies. I don't know, I couldn't understand why you would get non-cardiogenic pulmonary edema, but that's the explanation, which doesn't help me any, understanding it. The other things are pretty straightforward. You can get electrolyte imbalance. I mentioned blood is hyperkalemic. But in the setting of trauma cases, they always do send electrolytes on these, well people who are involved in trauma. What the heck do you expect to find in a set of electrolytes in a well person who ran their motorcycle into a wall? Well, you're not going to find anything of any consequence, honestly, but it's just done. That's why it's just done. The idea here is a lot of adrenaline comes out during this accident. Adrenaline drives potassium inside the cell. We use that when a person's hyperkalemic. We give them a breath of albuterol, trying to drive potassium into the cell, because we want to maintain this ratio of intra to extracellular potassium. So you get high potassium here, let's just put it into the cell. They'll never even notice it, because there's 30 times more of it there than outside. But the ratio is important. The absolute number out in the plasma is important. Low calcium, because of the citrate issue. And here's another opportunity why your blood may be transiently hypokalemic. Citrate metabolized to bicarb, alkalosis. We know alkalosis is associated with low K. Acidosis is associated with high K. Diabetic ketoacidosis, what do we know about that? We know to expect that high K because leaks out of the cell in the setting of acidosis. Alkalosis puts it inside the cell. So bicarbonate is one of the things that we can give patients who are hyperkalemic. It's not as good as specifically giving calcium. Platelets are dead in 5 days. You have a person in the old days would donate a pint of blood, and they would take off the platelet parts, and that would be about platelets of, you'd get about 1 bag of platelets. After they pulled it off, it gives you 10,000 platelets. If you were to give it to the patient. So you take the platelets from a unit of blood, give them to somebody, and they would raise their platelet count by 10,000. So it basically would have virtually no consequence. If your platelet count is 200,000, 300,000, 400,000, giving a unit of platelets is of nothing. It doesn't do anything. If your platelet count is 10,000, and you were to give 1 unit of platelets, well, then you're now 20. If you were to give 5 units of platelets, which was routine in the old days, everybody gave 5 units of platelets. And the reason for that was to get your platelet count to 50,000. Once your platelet count is 50,000, you will not bleed as a result of a platelet problem. So it doesn't matter what your platelet count could be 0. If you get 5 units of platelets, you would be at least 50,000. That's where you wanted to be. So that's what people did. Now they don't have individual patients giving platelets. They have this platelet pheresis machine, which is an extraordinarily strange machine. You hook a person up to this thing, It sucks out all your blood and takes it out of this arm and puts it back into this arm. But in the meantime, it takes out all your platelets. And you can give platelets 40 times a year. You're allowed to give platelets 40 times a year. That's how quickly you replenish them. You can give your plasma something like 13 times a year if you're a donor. You want to, if you fall on hard times, 13 times a year you can give your plasma. Platelets, you can give it all the time. And you sit there and it extracts all of these platelets and gives you back all your blood. And because you have 200, 300, 400,000 platelets per whatever the unit is, you have lots of platelets, so they can take out lots. So now the platelet pheresis pack has the equivalent of 5, 6, 7, 8, 9 of the single donor packs in one platelet pheresis pack. So you're giving a platelet pheresis pack, you're giving 6, 7, 8, 9 units of platelets, depending on the platelet count in the patient. So that's what they do now. Amazing machine. Platelets do need to be ABO compatible. It doesn't take long to determine what your blood type is, but because you can't get rid of every red cell when you're doing this process, it literally takes minutes to determine your blood type. I remember when we used to do physicals for the police department, and they wanted to know, hey, listen, doc, we want to know our blood type, so we can put a card in our wallet, so that if we get shot, you'll know what kind of blood to give us. And I said, we're not looking in your wallet. The only thing we're interested in your wallet is your Blue Cross card. You think we're going to, it's B positive. Let's send that out. No. We send it to the lab. We know, honestly, in minutes what your blood type is. So, but no, they needed a card showing their blood type kind of thing so they can shot. Platelet disorders, remember non-palpable purpura is what we get when we have bad platelets or low platelets, versus the palpable guys, which is the vasculitis kind of thing. Dysfunctional platelets, you can have all the platelets you want, but if they don't work, then that's an issue. So your platelet count could be normal, but you gave this person some Plavix. Plavix, $9 billion in sales, $9 billion for Plavix. Only topped by, there was probably a drug or two in the middle there, but the highest selling was Lipitor at $12 billion a year. But the patent expired in 2011, and now it's probably down to nothing. But $12 billion a year for people who would likely get no benefit from taking that drug at $6 a day. $6 a day. Number needed to treat for you to prevent that. We don't care what your cholesterol is. Number needed to treat to prevent your heart attack because you have high cholesterol. Probably in the neighborhood of minimum 60, 70, 80 patients a year for 5 years have to take a $6 a day tablet to prevent one heart attack where the mortality is 6%. Huge. And if you told your patients that, well, it's only going to work for 1 out of 80 of you, or 90, and you got to take it for 5 years. And by the way, it's $6 a day. Oh, thanks, doc. Appreciate that. Wow. That has got nothing to do with this talk. I just feel better getting this off my chest, So there are some other drugs that can also screw up your platelets a little bit. We don't really know about them. It's interesting. Plavix, you would think, well, somebody gets whacked on the head and they're taking Plavix, or they're taking Coumadin. Oh, that's dangerous. We have 2 papers in the Emergency Medical Abstracts database, which I'm sure every one of you subscribe to here. That's why you're here on the last day. You are anal. That show that the outcomes are worse if you bump your head and you're on Plavix than if you're on warfarin. 2 papers unequivocally worse if you're on Plavix versus platelets being a little messed up with that. That's not bad. Warfarin, oh, that's bad. Platelet disorders, we can make less of them. And the drug that I like here the most is ethanol. Ethanol is a bone marrow kind of toxin. And so this is kind of like chronic alcoholic patients who fall and hit their head all the time. And you measure their platelets, they got 60,000 platelets kind of thing, because this is commonly seen in the setting of chronic alcohol, because alcohol is kind of like toxic. Heparin is a platelet killer, but it really doesn't apply to us because we don't give anybody any heparin worth talking about, and then they're in the hospital. You get the destruction of platelets, and we've talked about ITP, TTP, HSU, HUS, hemolytic uremic syndrome. We've talked about those things. Splenic sequestration, you've heard of that. Splenic sequestration, what the heck is? Well, the idea is here is that you can get a lot of blood into your spleen, particularly in a kid. A kid's spleen can hold 50% of their blood volume if it's kind of stuff is going in, and for some reason stuff is not coming out. So the idea is the spleen gets bigger, 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 and that is particularly seen in sickle cell disease, and it could be a source of some really, you become hypotensive because the sickled cells block up the blood vessels from spleen emptying. So that's splenic sequestration. That's the trapping of red cells. But it's not the same as hypersplenism. You've heard of that. Hypersplenism is that your spleen is overactive and is prematurely destroying red cells and platelets when they shouldn't be. Hypersplenism. And you get platelet loss through bleeding. Immune thrombocytopenia purpura. We're going to go through this much more quickly in the slides here. About maybe 10 years ago, the ABEM said, we're going to do all these articles that you need to read, and then we're going to put them in the exam. I said, oh, God. So we had a thought, each year we'd have to contaminate our lectures with all of these articles that had nothing to do with emergency medicine that they were picking. And the first year they picked an article on ITP. It was an internal medicine article in the New England Journal. It had virtually nothing to do with emergency medicine. The emergency medicine part was about this big, and all the rest was just totally irrelevant. And it was like, God, is this what we're going to get ourselves into? In any case, immune thrombocytopenia purpura is, some people call it idiopathic thrombocytopenia purpura. It was still ITP. We know the cause. It's an immunologic reaction. We don't know what the trigger of this immunologic is. So the idiopathic is correct because we don't know the trigger. Immune is correct because we know that as the mechanism, and it's really simple. For some reason, people stop making platelets, or they destroy their platelets. And that's all. That's the only thing wrong with them. They start developing like ecchymoses and those kinds of things, and you do a CBC and the platelet count is 30,000, and that's it. Everything else is fine. Nothing else is wrong with them. And so the issue is that it gives us an opportunity to talk about the significance of platelets in terms of bleeding. So you're above 50,000, you should be okay. 50,000 to 30,000, you should have excess bleeding associated with trauma. 30,000 to 10,000, spontaneous bleeding and bruising. Less than 10,000 or less, you get visceral bleeding. That's bleeding in your head, serious bleeding. So we can't be anywhere near that number. And if you come in and you are bleeding, actively bleeding, and you got any number less than 50,000, you got to fix that number. You got to fix that by giving them some platelets. Now you know that if you give somebody one unit of platelets, it'll raise their platelet count 10,000. If you give them 1 unit of plasmapheresis, that should take any soul and get them well over 50,000. So that you just order up, can we get a 1 platelet pheresis pack? Thank you very much. And basically that will take care of the problem as long as they're not continuing to. The problem here is that you give good platelets, and this process that is destroying the platelets will destroy the platelets that you're giving, the good ones. So you have to give 2 to 3 times what you would think to be the amount that is necessary. And before you do that, you have to give them a big slug of steroids to suppress the immune system so that you can protect the new platelets that are being put into this bleeding person. So there's where we talk about active bleeding, the threshold. If you're less than 50,000 and bleeding, you need platelets. Suppress the immune system. The only reason I like this RhoGAM thing, I can't envision the masking, and so don't get angry with me. But this is very cool. RhoGAM, we give RhoGAM to mothers whose negative blood, Rh negative blood, has maybe contaminated with some Rh positive blood from their new kid. And so we give this RhoGAM, which is IgG antibodies, trying to find all of the Rh positive cells, seek out and destroy those cells so the mom is not sensitized to these Rh positive cells. That's what RhoGAM does. Antibodies seeking out the positives in a negative mom. In this case, We give RhoGAM to a person who's Rh positive. You give Rh positive, you give all of these, we're going to give to this person who's Rh positive this stuff that's going to seek out and destroy Rh positive cells? The answer is yes. And we do it in this case because the spleen will say, we got all of these damaged cells that have been screwed up. They got these antibodies that are Rh positive, destroying Rh positive cells. Our job is to take care and finish off the job. So the spleen gets confused. We got to destroy these red cells. We got to destroy these platelets. We're kind of enough. So basically, the idea here is now the spleen, instead of just destroying platelets, is trying to destroy red cells. It can't do both. And in essence, we're willing to sacrifice some red cells to save the platelets. Very strange. Immune thrombocytopenia. Basically, we're just concerned about you bleeding in the head. I don't want to talk. This is way overdone. I want to skip this till we go here, and then we'll go back to those others. This is the clotting cascade. I know that you all study this religiously, alternating with the Krebs cycle. You know, this is one of the things that frightens us. This is for hematologists. This is not for ordinary doctors, no less emergency doctors, to deal with this. But the fact is, it is much more easily understood, I think, than not. Extrinsic pathway. Everything in emergency medicine that matters happens on the extrinsic pathway. What triggers the extrinsic pathway? Extrinsic pathway is triggered by tissues being crushed, injured, capillaries being broken, and so there's this tissue juice. This tissue juice gets into the bloodstream. The tissue juice triggers the cascade. There are other things that trigger the cascade, like meningococcal bacteria get in there, meningococcal bacteria, or products of conception get in there, or you have a big whack on the head and you've got a lot of brain injury there, and into the bloodstream goes these phospholipids, and those trigger we know that head injuries are associated with DIC. And we'll talk about that in a second. But anyway, they trigger the extrinsic limb of the clotting cascade. The extrinsic limb of the clotting cascade is measured by the pro-time, and the pro-time, and we screw up that limb by giving warfarin, which inhibits the production by the liver of factors 2, 7, 9, and 10. 2, 7, 9, and 10. Vitamin K is needed to make 2, 7, 9, and 10. So we can inhibit, if we don't get enough vitamin K, then we won't have enough 2, 7, 9, and 10. You need bacteria in your gut to produce the vitamin K that goes into the liver. So if you take an antibiotic and kill all the bugs in your gut, or at least some of them, then you run out not having enough vitamin K, and if you're on warfarin, your INR goes up. So that's basically, that's the limb for DIC, which we'll talk about in a second. DIC basically was triggered by this brain tissue, and you wind up making clots, and these clots consume the clotting factors so that the platelets go down and the fibrinogen goes down and these clots form. And these clots can basically go showered through the bloodstream. And in kids, when you saw pictures of kids who had meningococcemia, they had black fingers, black toes, black hands, black feet. All of these distal tissues were ischemic because these clots clogged up all of their terminal blood vessels there. So those that lived basically wound up having all of these amputations because they had DIC and they formed these clots. The other version of DIC is we consumed all these clotting factors, and now we've got bleeding at the IV site, the NG site. The wounds are starting to ooze that were not bleeding before. So you can have, with DIC, you can have bleeding or these clots, and one might predominate over the other. So everything we want is on the extrinsic limb. The intrinsic limb is triggered by platelets recognizing that they are not in the lumen of the blood vessel. And when they recognize that, they say, "Hey, Frank, I don't think we're in the lumen anymore." And they agglutinate. In the process of agglutinating, they release some factors that trigger the intrinsic limb of the clotting cascade to form their clot. So that's triggered by platelets. That is why every day you take your baby aspirin to try to screw up your platelets so that when they recognize that they're not in the lumen, they're kind of slow on reacting. So that's kind of like to prevent your heart attack from that when you break that plaque in your coronary artery, that these platelets don't pile onto the top of that plaque and then really occlude the artery. So the idea here is we take a baby aspirin once a day to screw up our platelets because they are the activators of the intrinsic limb of the clotting cascade, and we know that plaque rupture and a clot over top of it is the mechanism of a heart attack. So every day we take a baby aspirin, and every day it screws up all of our platelets. As soon as you take that aspirin, it screws up every one of your platelets. And then over time, during the day, you get more and more good platelets, and at the end of 4 or 5 hours, that aspirin is out of your body. So you're making new platelets, and so you have this admixture of platelets that don't work so well mixed up with good platelets. And so at the end of the day, you take another aspirin, screw up every platelet, and start all over. So when would you take your aspirin to try to prevent a heart attack if you were given one aspirin during a week? You only get one aspirin. When would you take an aspirin? Anybody? Sunday night. Sunday night. Why? Because heart attacks happen Monday morning. Statistically speaking, in men, platelets get stickier in the morning, blood pressure goes up in the morning, there's more stressors in the morning because you got to go to work, damn it. Now that only applies to people who work Monday to Friday. Now, God knows when it would happen with an ER doctor, because there is no Monday to Friday, except for you who are the administrators. But that's true. I mean, if you only had one aspirin a week, you would take it Sunday night if you were a Monday to Friday worker. So that's the intrinsic limb. What else screws it up? That limb is screwed up by heparin. Heparin is reversed by protamine. And what is the pathology on that limb? The only pathology on that limb is hemophilia A, hemophilia B, and von Willebrand's disease. That's it. And we don't care about any of those in terms of making the diagnosis, because patients are going to tell us, I get hemophilia, I get von Willebrand's, maybe not about von Willebrand's. But the fact is that for all practical purposes, there's nothing on that limb that matters to us. That limb is measured by the PTT, and you should be allowed 5 PTTs a year. Instead of this automatically, proton PTT. Doctor, you want a proton PTT? It's like it's one test. Proton PTT? Okay, proton PTT. It means like, well, we don't know what the hell we're doing if you're ordering both. You don't need both. PTT is only about intrinsic limb. Intrinsic limb is hemophilia A, B, and von Willebrand's disease, or a heparin overdose. Your patients are waiting so long in the emergency department that they're giving out heparin so they don't get any clots out there. That's it. Now look through this thing and see all the places where there's calcium. You know, you need calcium to make these clots form. The other thing we'll talk about is these new anticoagulants. And where do they fit in this thing? Well, we have the 10A inhibitors. Look where 10A is. See the there's two final common pathway. 10A is on the final common pathway. The warfarin, the proton measures and the PTET measures these limbs. They measure the final common pathway a little bit, but not very well. And look where the thrombin inhibitor, look where thrombin is. Thrombin is just about right before the formation of a clot. Thrombin inhibitors are at the end of the clotting cascade. So measures of the intrinsic or extrinsic limb are not going to tell you what you want to know about what's happening down in the lower part in the final common pathway. All right, so that said, let's go back to test of hemostasis. Bleeding time measures platelet function. Bleeding time measures platelet. Well, we don't do bleeding time anymore. Now we do a platelet function test. The old days, they would come over and scratch you with an egg timer and see how long it took you to stop bleeding. And that made a lot of sense, actually. If you have a bleeding diathesis, we'll just make you bleed and see when you stop. And I remember Gonzo, the orthopedist, whenever he had a broken hip, he would order bleeding time in the patients. And he would come with the filter paper and the egg timer and time this thing. But actually, it's a measure of the platelets, whether you have enough of them, that's easy to measure, or how they work. Because there are the conditions. You got the aspirin, you got the Plavix, you got the uremic patients. You see the uremic patients? They got black and blue marks all over the place. They got normal number of platelets, but their platelets are dysfunctional. So, so we got that. And what's this von Willebrand's thing? Von Willebrand's disease, it's a genetic disorder. So von Willebrand disease is in the blood vessel wall. And when you injure the blood vessel, this stuff comes out of the wall and facilitates platelets recognizing where they are. So if you have not enough von Willebrand disease as a result of a genetic problem, then you injure the blood vessel wall, you don't have enough von Willebrand's disease, the platelets are not really good at determining that they need to get together, and they don't. So they don't trigger the intrinsic limit of clotting cascade because they need von Willebrand's disease, factor to do that. If you have too much von Willebrand's disease, as in TTP, as in hemolytic uremia syndrome, too much of it, then platelets clump prematurely when they shouldn't be clumping. And in those cases, they don't trigger all the rest of the clotting cascade. So test of hemostasis. ProTime, we talked about that that's the measure of the extrinsic limb, which is our limb. That's what we're interested in. It's screwed up by warfarin, DIC, vitamin K deficiency, liver disease. It's measured by the INR, or the PTT is an intrinsic limb. That's the heparin limb. Hemophilia, von Willebrand's. Forget the lupus thing. I don't know what that is. Platelet count. I think we talked about destruction and production. We went through that. We went through this. DIC. Consumptive coagulopathy. We have dilutional coagulopathy from going all that red cells that didn't have the clotting factors. Now we have a consumptive coagulopathy. We're consuming the clotting factors in DIC. It was triggered by brain tissue, meningococci in the bloodstream, other things in the bloodstream that shouldn't be there, kind of thing, and it triggers the clotting cascade inappropriately. Shouldn't be clotting, and meningococcemia is kind of like the worst version of that. And if you're asked, what are the abnormalities in the lab tests of a DIC patient? Well, you're going to have a prolonged ProTime. That thing's screwed up. You're consuming platelets, so the platelets will go down. You're consuming fibrinogen, because you need to make clots out of fibrinogen, so that we're consuming that, so that's going to go down. We made all these micro little clots, and so we're going to be lysing clots, and so we're going to have fibrin degradation products go up. The one we know now is D-dimer, so that's what we measure if we think somebody has a PE or aortic dissection or something like that where they get a big clot. So we're measuring that fibrin degradation product specifically. So that's kind of what you would find. Treatment of DIC is, are they bleeding or are they clotting? If they're throwing all these clots into the extremities and you got gangrene at the toes and fingers, then the idea is maybe those patients would benefit from heparin, which is kind of a gutsy thing to do in a bleeding patient. But this person's got DIC, and that's the predominant finding. Or they're bleeding. If they're bleeding in the IV sites and the wound sites because of DIC, and you measured it and you determined by those other tests that was going on, then basically you need to replace clotting factors. Fresh frozen plasma is what you often used. If I were to ask you how much fresh frozen plasma you would give to a person who is bleeding, since we rarely do that, if I didn't already have the answer up here, most of you would say, I'd give 1 or 2 units of fresh frozen plasma. The factor is that that's substantially under what they need. They need 10 to 15 mLs per kilo. So the 100 kilogram person needs 1.5 liters of plasma, fresh frozen plasma. That's a lot. It has to be defrosted, it's thick, it runs in slowly. So the options, fresh frozen plasma, yeah, it has the clotting factors, but and there may be some issues of overload in maybe older people who can't handle getting 1.5 liters of something. But that's what you're supposed to do. Thrombotic thrombocytopenic purpura is the same thing as hemolytic uremic syndrome, but didn't we talk about this? I think that basically the idea here is we don't know the trigger to this one. We knew the trigger for hemolytic uremic syndrome. That was the E. coli that had sex with the Shigella. But this, we don't necessarily know what the trigger is. It could be pregnancy, it could be idiopathic, it could be some other kind of preceding infection. But you get the same kind of thing where blood vessels, primarily in brain and kidney, they start leaking out von Willebrand's factor, causing clumps of platelets to form against the walls, decreasing the flow and causing ischemia and breaking up all those red cells and causing the helmet cells. And in this case, the problem is primarily a problem with the brain. In the kid's case, hemolytic uremic syndrome is primarily with the kidneys. Both organs are infected, but in this one, it's mostly the head versus the kidneys. A little chart here, you can study that if you want. Heparin, you know about heparin doesn't cross the placenta, so that's what we can give to people, women who are pregnant who need it to be anticoagulated. Low molecular weight heparin, the companies chop up big heparin into little heparin. Little heparin still doesn't cross over the placenta, and it works on the clotting cascade in a different spot than regular heparin. So some of it works pretty down the clotting cascade. So measuring the PTT, as you would if somebody got normal heparin, when you use low molecular weight heparin, it's not very accurate, doesn't help. The idea here is you don't need to measure it. It is weight-based. It'll get you into the area that you need to be, and so that's kind of the advantages of low molecular weight heparin. Each company makes their low molecular weight heparin their own way. Some of it you need to take twice a day. Some of it you need to take once a day. In terms of it's very proprietary how they chop up big heparin into little heparin. Warfarin this is about 2, 7, 9, and 10. And down there they're talking about all of these things that can screw up your INR when you're on warfarin, like antibiotics, because that affects vitamin K, which affects your ability to make 2, 7, and 9, and 10. So a person comes in and they're bleeding and they're on warfarin, so you're basically supposed to stop the drug. It has a long half-life, however, so they need to be bleeding kind of not much. You can give vitamin K IV. Little risk of anaphylaxis if you do that, but it's actually faster. It's like, why would we give this stuff in a commando fashion IV when it winds up going to the liver, and there it's going to have to make all of this stuff. It's not like it's instantaneous. I mean, you can't give it by mouth or by some other way. So no, they give it IV, but it doesn't do anything right away. It's just a cofactor in the making of 2, 7, 9, and 10, which is going to take a little time. Is it faster by IV than giving it by mouth? Yeah, how much? Half hour? But anyway, that's what they do. And there's the fresh frozen plasma. But according to the American College of Chest Physicians, you ought not be using fresh frozen plasma. You should be using this prothrombin complex concentrate. In the United States, we had a three item, 279 or whatever, 3 of the 4, and now we have a 4, 2, 7, 9, and 10. Not each of them are equally important. 7 is disproportionately important compared to the others, but now it's out there, and this is what they say. They say, don't screw around with this. Although fresh frozen plasma can be given in this situation, immediate and full correction can only be achieved by the use of factor concentrate because of the amount of fresh frozen plasma required, which I told you is like 1 liter or 1.5 liters to correct INR. So it may take hours to infuse it. So basically, they say this is what you should be doing, American College of Chest Physicians. This stuff costs about $2,000 a dose of this stuff, so it's not cheap. And the four-factor version was released about 6 or 8 months ago. The rest of the world has had it. 20 countries has had 4-factor before we did. I have no idea why we don't have 4-factor. It's a little bottle, You reconstitute it, in it goes. $2,000. Don't drop it. And this is the new guys we talked about. One of the things that you should know is that they work so far down on the clotting cascade, we can't really measure them very well in terms of, and they're put out by the kidney. The direct thrombin inhibitors, look at this, Pradaxin, dabigatran, 80% excreted by the kidneys. So you got to have good kidneys, and basically the idea is to wait it out. Half-life is relatively short. You're giving this stuff once or twice a day. So if you can wait it out, do that. Factor 10As are not excreted by the kidneys as much. I think these are going to turn out to be the winners. Apixaban, I think there is in development an antibody specifically that will neutralize apixaban. So this idea of, we can't treat this stuff anymore, I think that this will be resolved. This is used for atrial fibrillation, and people up to age 75 seem to get a better result using this stuff than using warfarin. They don't tell you about the people over 75. People over 75 get a worse result. Details. I don't think there's anything further on here. But the big thing is renal, little bit renal here, a lot of renal in the thrombin inhibitors. Oh, God, look at all this stuff. This basically says this stuff is short-acting. Try to see if you can wait it out. If you can't wait it out, you're going to wind up throwing the book at it. You're going to throw the prothrombin complex concentrate at it. You're going to try to do everything that you can. But it's a problem. So there's about this normalization of this thing and how long it takes to do it. And direct thrombin inhibitors are better than the thrombin, vice versa in terms of the renal excretion. Tranexamic acid, you can throw that at it too, put that in there, Desmopressin. Desmopressin is antidiuretic hormone. What's antidiuretic hormone got to do with any of this stuff? Well, antidiuretic hormone also tends to cause your blood vessels to release their von Willebrand's factor. And the more von Willebrand's factor that is out there, the more factor VIII that they can carry, and having an extra factor VIII may help in stopping this bleeding. Who knows? But it's like throwing the kitchen sink at them because we really don't know what works best and we don't have a good answer. Sickle cell anemia, 6 to 9 hemoglobin kind of thing here. We worry about the painful processes, but it's this chronic anemia that they have. It's a lysing of red cells so that they're always icteric. Spleen's always acting to destroy these cells. So their spleen is a little overactive. They're making red cells to replace the bad ones all the time, so the retic count is high, 5 to 15%, as they point out there. And they all have basically no functioning spleens because spleen is one of these vessels that has a disproportionately large volume of blood goes through it. Spleen takes care of all of this work of destroying old cells. So the idea is that blood vessels, the spleen is getting loaded up with these sickled cells. They sickle in the spleen, so blood goes in, nothing comes out at the back end kind of thing. So the spleen, because nothing's coming out at the back end, the spleen is, at the back part is all basically ischemic, and over time the spleen dies. And so all of the kids who have sickle cell have no functional spleens, and so the spleen is needed for taking out of your circulation bugs that the white cells don't handle very well, and at the top of the list are the bacteria that got these little jelly coats around them, and that bacteria with jelly coats around them is pneumococcus. So they were particularly prone to pneumococcal sepsis prior to the development of the vaccine against it. So all of the febrile kids who had sickle cell, who came in and were diagnosed with the flu, who were sent home and ultimately had pneumococcal sepsis and died, the lawsuit was, are you aware of the idea about pneumococcal sepsis? Why did you call it the flu in this little kid who has sickle cell and had a fever? mom and dad. The vaso-occlusive crisis or musculoskeletal, back, extremities, we know about that. And the second one most common one is abdominal pain. The abdominal pain is very stereotypical. It's the same, no peritoneal signs, no rigidity, it's diffuse. The precipitants seem to be, if you look at a common denominator, is need for more cellular oxygen. So cold exposures, infections, exercise, things like that. But a lot of times we don't know the trigger. Maybe an infection that doesn't appear apparent. This is in your book, and those of you who are using your computers, you can see this better than the book can, that's for sure. Acute chest syndrome, this was another one of the horrible LLSA articles, New England Journal kind of thing, everything you could possibly want to know about it, about this much related to emergency medicine. So this is basically a pulmonary infiltrate in association with sickle cell. Usually develops a couple days after these kids are admitted and they're admitted for pain and management. Next thing you know, they're short of breath. Take an x-ray, they got this infiltrate. So they've got this fever, they've got this infiltrate. What is this infiltrate? We don't really know. So the study was about what is the infiltrate caused by. Is it a pneumonia? Is it a pulmonary infarction? Is it a secondarily infected pulmonary infarction? Is it due to fat embolisms causing this lesion? But it could be a little of each. So the idea was at the end of the study, which was this long, or this review, they said, number one, treat these as if they have an infection, and the infection we're concerned about are mycoplasma, so give these people erythromycin. Number two, assume right off the get-go that people who are starting to have these symptoms need incentive spirometry, give them inhaled adrenergics, even if they're not wheezing. It was all trying to be preemptive because a lot of these people went on to respiratory failure and had to be intubated. So the idea was new pulmonary infiltrate. They had some chest pain, fever, and concomitant tachycardia, wheezing, tachypnea, that kind of thing. So this is the issue about what was causing it, those combinations. And then they had this at the end of the paper, here's what we do to deal with this. So oxygenation, antibiotics, macrolides, mechanical support, incentive spirometry, pain management, bronchodilators, etc. This is other sickle-related crises, including like strokes, priapism, renal infarctions. These infarctions that are occurring just in the spleen can occur other places as well. Hand-foot syndrome is basically these avascular necrosis, the kids in their fingers and joints, and so there's this variety of them. We talked about splenic sequestration. This is typical of sickle cell. Aplastic crisis, often due to some viral infection. Basically, instead of having a 15% reticulate, just stop. They stop making red cells. We're out. We're tired. So the idea is basically to give them the substrate to make red cells. So they're talking about giving them vitamins and iron and things like that, and folate to make up for it. This is the relationship between the bacteria that have the jelly capsule around them, the pneumococci, pointing out also that they are particularly susceptible to salmonella bone infections, and that's this kind of biz-buzz of sickle cell and not. They need to be immunized against all infectious diseases that we can think of, and so they've done a lot better now that we have all of these immunizations. And this is, basic stuff. We're not going to get into There's two options. At the end there's transfusions, giving more red cells that won't sickle, and number two, pulling out the sickling cells and putting in good cells, which are these exchange transfusions, which occur, rarely, but when they're really bad. Malaria, we've got malaria in here, is, so look at these numbers. World Health Organization, 219 million documented cases in 2010, malaria. So people going over to Africa for a little vacation, I have no idea who would go over to these areas of Africa for. I wouldn't view that as a vacation. If you want to go to the same area, just take a ride about 10 miles down the road, and you're in the same general vicinity of desert. But in any case, this is a female mosquito, bites you, puts in this little malaria parasite, lives in the bloodstream, multiplies it in the blood cells. The blood cells pop, they come out, attack other cells, they live in those cells, blood cells pop, so they have this idea of having periodic severe fever. Starts out like a flu-like illness, and the idea is, have you been traveling a lot? You get a blood smear, you see these little bugs in the red cells, and you've made the diagnosis. Incubation, little, not right after you got bitten kind of thing. So you get these rigors, bad fever, periodically, depending on it's of the 5 varieties. They have Vivox and falciparum are the 2 that are most common and most problematic. And when you're killing lots and lots and lots of red cells by these little parasites, you start pissing out free hemoglobin, and you got your urine starts turning a little red. Black water fever. So this little thing shows the little bugs in the red cells. Dengue fever is another one, mosquito thing. Tropical illness. This is not from the desert. This is from the tropics. So you go down to some nice tropical place and you come back with another flu-like illness. Both of them starts out like flu-like illnesses. And this a mosquito basically injects this virus into you. This isn't a virus. It's not. The other one is a parasite. This is a virus. And this virus starts multiplying like crazy and starts causing inflammations, and you got the joints, and they get the fever, and you got what's called breakbone fever, because the fever is so bad and the shaking is so intense that it's in many ways similar to malaria, but the smear is not positive at all. And this worst form down here, this virus basically attacks the bone marrow, and you stop making platelets, which are made in the bone marrow. Next thing you know, you're bleeding all over the place because you have a bleeding diathesis caused by a huge takeout of your bone marrow. The thing about this one, too, is you do get a rash. This also would distinguish it from malaria. This is like a measles-like rash, they say. Hemophilia, factor VIII, destroys joints because blood destroys cartilage. And in the old days, most of the folks had HIV because of the fact that they were given blood products that were contaminated with the virus. If you really want to see a great movie on this, have you seen Bad Blood? It's on Netflix. Go watch Bad Blood. It's about the pharmaceuticals industry's behavior in dealing with pooling all kinds of blood specimens together, giving them to people, causing a lot of problems. It's one of these exposés. Bad Blood. It's a great movie. Hemophilia A. Women give it, men get it, and most people who get it bad. Factor VIII percentages are very low. That's factor VIII. Factor IX is hemophilia B, less common, tends to be less severe. Bleeding into the joints, bleeding into the head, bleeding into the neck, those kinds of things. So a hemophilia patient comes to you with a headache. You would normally send them to a CAT scan. I guess a lot of people who have hemophilia can travel with their factor, but if something like that did not occur and they said, I have hemophilia, before you would order a CAT scan, the treatment that you're supposed to give is arginine vasopressin. Arginine vasopressin, basically antidiuretic hormone, does von Willebrand's disease. Von Willebrand's disease does 2 things. Number 1, it tells platelets to agglutinate or not, helps them understand that when they need to do that. Number 2, it carries factor VIII in the serum. So the more von Willebrand's you put out, the more factor VIII it will carry. So we want to get von Willebrand's out there, and one of the ways to do that is with arginine vasopressin. Arginine vasopressin is technically called diamino D arginine vasopressin. So if you take the initials, it's DDAVP. So it's easy to say DDAVP, arginine vasopressin, same thing, antidiuretic hormone. But interestingly enough, DDAVP is the trade name for some company's version of arginine vasopressin. They just took these letters and said, we're now calling our stuff DDAVP, which you would never have intuited that. You would think that well, that's just the way we abbreviate this thing. No, it's a trade name. Little rats. So basically, you have to have a low threshold for treating patients empirically who have a headache. And that's what this thing says. Otherwise, you give them factor 8 if they have it, which they give it themselves. You don't need you to do that. So that's the emergency treatment for us to know. Arginine vasopressin increases the von Willebrand's factor by a factor of 8. Factor 8 level by a factor of 3-fold within 1 hour. Very quickly works. Von Willebrand's disease, most people who have it don't bleed. This is basically you don't make enough von Willebrand's factor, therefore you don't carry very much factor 8, and your platelets don't agglutinate when they ought to. The treatment is the same, actually, DDAVP, because DDAVP brings out von Willebrand's factor. Von Willebrand's factor increases the amount of it, and that's the problem in this condition. You don't have enough of it. It brings it out. We're just going to go quickly through this. Lactic acid doses. Some of these drugs are so toxic, basically, that they shut down aerobic metabolism. They damage cells, and they switch over to anaerobic metabolism and lactic acid doses from the treatment of these drugs. Immune reconstitution syndrome is basically the drugs now can be so good that you take this immune system that is not working, and basically you take it to an immune system that is overreacting. So that basically this immune system now is looking for all kinds of trouble. So it finds the dormant TB and attacks that. It wasn't bothering anybody. Attacks that. Fever, immunologic war, granulomas are formed, and you had a sore throat 2 weeks ago. You're fine now, but there's still some antigens around from that sore throat. It says there's an antigen for an infection. Let's go attack it. So the next thing you know, you've got fever, chills, and myalgia because the immune system is trying to treat and fit and deal with this sore throat antigen, which it's only left over. The clinical illness is over. So immune reconstitution syndrome. Some of the other things that it can be issues are rashes and kidney stones and really, this is a moving target, so I don't think we need to spend much time on it. We do need to spend time on the emergencies, though. Eye emergencies, the way you can remember this, cytomegalovirus. Well, what is the beginning of this word? Sight. Remember that. Sight, eye, cytomegalovirus. Basically, these are people who have T-cell counts of 50 or less, and they cause a retinitis and an inflammation of the back of the eye. Herpes zoster is in there too as an eye problem. The pulmonary emergencies, pneumocystis carinii. It's not in the carinii anymore. They felt the necessity to change the name to something else. But the bottom line is that this pneumonia doesn't require a T-cell count of 2,000. This is an infection that you can get at around 200. So, and the buzz of this is they have disproportionate hypoxia compared to what the X-ray looks like. They're sicker than the X-ray looks like. So that when you see that, they're low threshold for steroids and Bactrim, the treatment for these people. Pneumocystis carinii. Change the last name now. I'd probably had a big convention to do that. The brain things. This is the cerebral toxoplasmosis. This is where the ring-enhanced lesions. That's the buzz of that. The X-ray is, you can't miss it kind of thing. This is basically a little protozoal kind of thing transmitted by cats. So stay watch from the cat litter box. It's also from poorly cooked meat. And it goes to your brain, lamb and pork. And T-cell counts 50. And in the brain, it causes seizures and all kinds of neurologic problems, strokes, confusion. And Billy and the people at USC see this pretty frequently because people come from Mexico and have this. And then if you have meningitis, cryptococcal meningitis, this is the kind that they used to do India Inc. Remember India Inc.? Trying to find crypto means it's not very out there. It's kind of indolent kind of thing. It's kind of hard to grow and see. So this is the ring-enhancing lesions of toxoplasmosis. Can't miss those. So if they gave you this in a picture, and then here's the most common things. This is why people with HIV would go to an emergency department, most likely, and it's for something related to a GI matter, either an infection or diarrhea, from the mouth to the anus. Everything that you can think of, also involving the liver as well. Every parasite, every infection that you can think of is on this list. The oncologic emergencies basically come into compression of stuff or biochemical derangement. We'll talk about the compression first. That's the easiest. Also, we're talking about, at the very end, the idea about getting infections because you're myelosuppressed because you had chemotherapy. So the spinal cord compression, big ones are lung, breast, and prostate. Lung, breast, and prostate. Just remember those. They go to bone. Lung, breast, and prostate. Also multiple myeloma, renal cell cancer, and lymphoma. But remember lung, breast, and prostate. Having cord compression obviously is obviously not a good thing. Look at where these cord compressions are occurring. 60% are thoracic. So thoracic back pain is a red flag. Thoracic back pain does not occur as a result of lifting a box at work. The pain of lifting boxes is lumbar or neck. Those are the mobile portions of your spine, lumbar or neck. You have thoracic back pain. Thoracic back doesn't move. It's like that. So anybody that comes in with thoracic back pain, you got to get a little nervous about in terms of spinal epidural abscesses could be there, and these pathologic issues of compressions. And so that's kind of a red flag. Obviously, the neurodeficits, you can kind of anticipate what they would be. They need a MRI is the ideal test to see what's going on. You can see the spinal cord compression in that. The vertebrae basically can have a pathologic fracture. They can have bleeding into it. The tumor could invade the vertebrae. There's all kinds of mechanisms for this to happen. It's not just it grew there. Airway, it's related to tumors around the airway. So thyroid and carcinoma of the larynx, blocking up the airway. Airway obstruction is pretty straightforward. Pericardial effusion, the two cancers that are most likely to cause pericardial effusions are the ones that are around the heart, breast and lungs. That's how I remember it, breast and lungs, around the heart. But the melanoma, it has a particular predilection for going to the pericardial sac. It's not as nearly as common as breast and lung cancer, but it likes to do a pericardial effusion. Other causes include radiation, chemotherapy, and infections. And this is just a restatement of the findings of a pericardial tamponade. I don't want to go through this again. They're pretty straightforward. You'll review it. Superior vena cava basically is lung cancer, lung cancer, lung cancer, and basically it blocks off the drainage of blood out of the head, so the head becomes effused with blood. Blood tries to get around back through extremity and chest veins, so they become prominent. You have increased intracranial pressure, so they have headaches, nausea. They start getting lethargic kind of thing, and there are some other causes that are listed there. See that picture? Who's that guy at the bottom? Anybody recognize that guy at the bottom? That's Sherman Hemsley. He was in, what was the name of that show? Yeah, the Jeffersons. Well, he didn't have a face like that, the Jeffersons. He died of lung cancer, and this is basically when he had his superior vena cava syndrome. You can pretty much intuit most of these things. The head is full of blood when it shouldn't be full of blood. And the dyspnea, cough, and hoarseness, I think, is more related to the fact that there's a tumor here that is causing blockage of some element of the airway. This is a lung cancer patient, so that may be causing some of this as well. Diuretics and steroids, it's really about irradiation, but you're not doing that in the ER. Hypercalcemia. Hypercalcemia is not good in cancer patients. It means that you don't have a lot of time. A substantial subset of admissions to the hospital are for hypercalcemia. It says something like 60%. I'm surprised that number is that large. Where does it come from? It comes from tumors making parathyroid hormone substitutes. It's not about invading of bone, lung, breast, and prostate and all that other stuff. 80% of hypercalcemia is due to this manufacturing of parathyroid hormone-like substances so that you raise your calcium up. You can see that 20% is due to the invasion of the bone and the leaching of calcium out of the bones for that process. Signs of hypercalcemia. Everything slows down. You know that if you have low calcium, and your reflexes are very brisk, or tetany, hypocalcemic tetany kind of thing. Well, opposite. Just think the opposite of what will happen. So you'll have the muscles will become sluggish, the bowel becomes sluggish, the person becomes sluggish. QT interval is shortened. Dehydration. Hypercalcemia causes you to pee, so all of these people are dehydrated. So I think we've covered most of them. Oh, hypertension. Why would you think of hypertension? Well, we know calcium channel blockers are used to treat hypertension, so that may be helpful to remember that if there's excess calcium, maybe there'll be high blood pressure. Calcium channel blockers are used to treat hypertension, so that may be a way that you can think of this. There is this relationship between calcium and albumin, so people who have high albumins or high protein levels have high calcium levels. Like in myeloma protein in the bloodstream, they're going to have high proteins, high calciums. But this is the unionized calcium. It's biologically inactive, but there is a relationship between this calcium and the ionized calcium. So if you have high protein, you're going to have high calcium. You'll probably have a little bit on the higher end of high ionized calcium. And the starving people in the nursing homes have low albumin, low calcium, but the ionized part is probably better than you would think. Calcium and phosphorus, product is 40, 11 times 4. So raise your phosphorus, you'll lower your calcium. That may be a treatment for high calcium, is giving phosphate. And this issue about pH. So you hyperventilate and you quickly make yourself alkalotic. When you make yourself alkalotic by hyperventilating, you take calcium that is ionized and biologically active and connected to protein. So you drop your ionized calcium very quickly, so you have the manifestations of hypocalcemia. So you start getting tetany or numb around the mouth kind of thing. Your hands are doing like so. Those are manifestations of low ionized calcium. And causing yourself to become alkalotic causes the ionized calcium to bind to protein, taking it quickly out of the bloodstream. And so when you stop, it goes back where it was and the symptoms go away. That's why the paper bag kind of thing is used. I have no idea what this says. I put it in there, but I realized then you can't read it. And I couldn't read it either. So the treatment I know of hypercalcemia based on cancer patients coming into you who are now symptomatic is hydration, hydration, hydration. After you load them up, then you give them furosemide. Furosemide will push calcium, excess calcium into the urine. You don't give them hydrochlorothiazide or anything like that. Those will do just the opposite. They will cause you to retain calcium. So this is a furosemide diuresis after they've been being rehydrated. Calcium, calcitonin, salmon calcitonin, would be the third thing to use because that's pretty quick. It inhibits the further resorption of any bone and increases the excretion of potassium. And then there's these other drugs, and all of these other drugs take a long time to work. So for ER purposes, it's those three things. Here's the short T of hypercalcemia. syndrome of inappropriate ADH. What is ADH? ADH is antidiuretic hormone. So if there was such a thing as diuretic hormone, you know that it would make you pee. Antidiuretic hormone prevents you from peeing, kind of thing. It is used to treat bedwetting. So we give this stuff inappropriately because it is elicited from tumors. And where are those tumors? They tend to be midline tumors. The brain, well, that's not exactly midline, but the thymus is midline, the duodenum is midline, the pancreas is midline, the prostate is midline. So those are a majority of them. I think there's also in here lungs. That's not midline, but most of them are midline. And they make a substance that looks for all the world like antidiuretic hormone. And so these people start retaining fluid. And what does it do? It drops their sodium. And so instead of 140, it's 130, 120, 110. And they can become symptomatic due to hyponatremia, due to dilution. It's a dilutional phenomenon. So if they're not very bad and you recognize this problem, you just restrict fluids. If they are getting kind of nasty, you kind of give them some diuretics. If they're really getting nasty, you give them hypertonic saline to get their sodiums back up to a safe level. But it's kind of, these tumors are making things that look like to the body antidiuretic hormone, causing dilutional low sodium. Hyperviscosity, basically a lot of white cells, a lot of protein, myeloma protein, macroglobulinemia. You get the sludging of flow, you get ischemia distally. And catch this, fatigue, headache, anorexia, somnolence. That sounds like something we just covered, which was hypercalcemia. Well, if you have a lot of protein, macroglobulinemia as an example, multiple myeloma, a lot of protein in it. A lot of calcium binds to it, a lot of calcium. So your serum calcium high. Ionized calcium may also appear to be high. So the fact of the matter is that this looks to all the world like, and it is really hypercalcemia. Clogged up blood vessels, basically. Rouleau formation of red cells is consistent with this hyperviscosity syndrome. Sausage-linked retinal vessels, that's for arterial occlusion of the eye. Kevin covered that, sausage-linked retinal vessel. It's all about sludged flow. Hydration is what you're supposed to do in these cases. The same thing as what you would do in hypercalcemia, because I think there's a substantial overlap between the two. There's your sausage-linked retinal vessels. Adrenal insufficiency, so you might have some cancer that has somehow affected the adrenal cortical axis or has invaded the adrenal gland and you're not making steroids like you need to. And so you get under a stressful situation, you get a fever, you get trauma, you have surgery where you're supposed to have a surge of steroids, and there is no surge of steroids. And so when are you supposed to consider this? In patients who have fever, dehydration, hypotension, and shock. All of those things, hypotension and shock, well, steroids basically cause you to retain fluids. You know, if you give people a lot of cortisone, they're going to get puffy and retain fluids. If you have lack of steroids, you're going to get on the dry side, and you're not going to be able to respond adequately to the stressors of an infection or some trauma. So the idea is you should be aware of this, and there'll be some things that kind of lead you to this diagnosis as well. And you just empirically give these people steroids after you're drawing a cortisol level. That's the safest thing to do. What clues would you have to suggest that this patient is low on steroids? Well, all of this stuff is the opposite of what you're used to seeing when you give steroids. So when you give steroids, we know that we don't give steroids to diabetics because it raises their sugar. Well, if we're low on steroids, we should get a low sugar. We know that we give steroids to asthmatics to suppress their eosinophils. So when you suppress your eosinophils, with steroids, if you don't have enough steroids, you're going to have eosinophils. Steroids suppress eosinophils. Lack of steroids increases eosinophils. We also know that when you give steroids to people, it causes sodium and water retention. Sodium and water retention. So in terms of the, when you have sodium retention, you pee out potassium. When you have lack of steroids, it's just the opposite, so your potassium goes up. So these are things to consider, that this may be consistent with the diagnosis. I'm going to give you 250 milligrams of Solu-Cortef. Tumor lysis syndrome is basically really pretty straightforward. you have a tumor that has lots and lots of cells that are particularly blood cells related, and you give this chemotherapy and you kill all these cells. And these patients then, all these cells lyse, and all the stuff comes out that was in them. And if this person happens to be dehydrated or have renal insufficiency, they're going to have a difficult time dealing with all of the intercellular contents that are being released. What's released? Potassium. So the potassium goes up. You know how to treat high potassium. That's one of the problems with tumor lysis syndrome. What else comes out of the cells? Phosphate. You remember that when your cells are dying in the bowel, the ischemic bowel, the phosphate is like a late finding. That's an intercellular anion. So your phosphate comes out. What does that do? It hooks up with calcium, so calcium phosphate. So your calcium is bound to all of this phosphate, dropping your serum calcium, making these crystals that lock up in your lungs and kidneys. You have your DNA and your RNA comes out. That is normally metabolized into uric acid. So now the liver, the kidneys got this uric acid to deal with. The uric acid crystals form uric acid nephropathy, calcium phosphate nephropathy, hyperkalemia, and hypermagnesemia, because that's an intracellular as well. So you're dealing with all of these items, and basically we're trying to you know how to deal with the potassium. Can't read that very well. The phosphate, this is about hydration, dilution, phosphate binders. You're dealing with the potassium. You know how to deal with that. One of the worst things that you can give these days is K-exolate. We thought that was the cure for high potassium. It is extraordinarily slow. It's been associated with bowel problems in terms of obstructions and lesions in the bowel. It's not a great drug. Uric acid, basically, this is one of the rare times when we alkalize urine. Urine is acid. There's very few times when we would alkalize urine. This is one of them. This will facilitate getting rid of the uric acid that is making the crystals in the kidney. And calcium. Now remember, calcium and phosphate are coming together, so the serum calcium is dropping. If you give exogenous calcium, the issue there is you only make more of these calcium phosphate crystals. So you would be ginger about giving exogenous calcium in these cases. So here's the hyperkalemia, BAM, look at that T wave. And here's the crystals. There's two crystals there. One of them is a snowflake kind of crystal, and then there's another one which is the needle crystal of uric acid. Needle is uric acid. Snowflake is calcium phosphate. And these are patients who got chemotherapy and they come in with a fever. So the maximum duration here was 7 to 10 days post-chemotherapy is when they're at their most risk for the suppressed white cells that they're dealing with. And basically, a good number of them have infections, and they get broad-spectrum antibiotics, because we really don't know. We culture them up and basically give them antibiotics. Rheumatology, let's go through this as painlessly as possible. So the idea here is you're supposed to aspirate these joints and look for these cells. One of the problems here is that the issue is non-inflammatory, inflammatory, and septic. And the septic and the inflammatory, you can see you can get 50,000 and be inflammatory, and more than 50,000 be septic, but they're kind of close together. But that's what you're supposed to do. You're supposed to check the white cells, check for crystals, check for bacteria, have a low threshold for aspirating red joints. Septic arthritis is staph, and staph. That is the worst, the most common. It is the worst in terms of what it does to joints. IV drug users generally get negative, gram negatives, and instead of into the peripheral skeleton, they're getting it into the axial skeleton. So they're getting it into their backs, spinal epidural abscesses, they're getting into costosternal junctions, the clavicular junctions, those places is where they get their gram negative infections. Septic arthritis, we mentioned the sicklers and this relationship with salmonella. There's a nice red knuckle. Gout, metabolism of uric acid metabolism is basically from DNA and RNA being catabolized. That's from protein. So it used to be called the disease of the kings because the kings got to eat a lot of meat. The people in the community didn't get meat. They got to eat out of grains. So this was considered the disease of the rich, basically overproduction, or you're not handling very well. You precipitate in your great toe. This is a place, honestly, where I would not tap a great toe. Person comes in, their great toe MP joint is red and swollen and hurts like heck. You send off a uric acid. You hope it's elevated. It doesn't have to be elevated. The treatment is NSAIDs or SAIDs. NSAIDs, okay. SAIDs are better, I think. Give them some prednisone. It works really well. I'm not into giving colchicine, but orally or IV. I think that, the idea is, well, give them enough so they get sick and then back off. It made no sense to me. Pseudogout is calcium pyrophosphate, and we don't necessarily know exactly what is precipitating that. It tends to be the bigger joints, and the nice thing about pseudogout is it's treated just like gout, but there are some radiologic findings of it. Gout is needle-like crystals. You look into the polarizing scope. Pseudogout, big rhomboid crystals, if you were to look at them. The treatment, so you basically want to give allopurinol, decreases production, probenecid, but acute treatment is the anti-inflammatories. You can start these things if you want to, but I would treat clinically first. Here's that toe. We've all seen that toe. The interesting thing about pseudogout is if you'll notice in the knee x-ray on the left-hand side, there's some white speckles in the cartilage, because normally you don't see anything. It looks like the two bones are suspended in air. So calcification of the articular cartilage is a sign of pseudogout. And so it's also showing up a little bit in the wrist, but it's more easily shown in the knee there. That's pseudogout, chondrocalcinosis. Gonococcal arthritis. Women, menses. Some people say it's not really menses, but fever, migratory arthritis, and the 2/3 of them have this hemorrhagic pustular erythematous base. Hemorrhagic pustular erythematous base. If you were to aspirate their joints trying to find the bug, it's not likely that you're going to find it. Treatment in these cases is generally empiric. We're going to start you on the antibiotics for gonorrhea in this setting. Blood cultures, again, not very likely to yield what you're looking for. But the hemorrhagic pustular erythematous base, that's the biz-buzz here. There's the gram-negative intracellular diplococci. That is the classic lesion. Lyme disease, so this is the spirochetal disease transmitted by these tick bites kind of thing. Erythema migrans, basically the tick bites you, in goes the spirochetes. Spirochetes start multiplying, moving out. So the redness, they're right underneath the skin, so they're moving out, so there's central clearing, supposedly, and erythema around. And this is like, there used to be syphilis, which was the great imposter, and it would cause every sort of disease that you can think of in terms of clinical manifestations. Now it's this one. Look at all the things that this causes. The joint problems, the neurologic problems. You get headache. The idea of calling it Bell's palsy is by a spirochete. Yep. Meningitis and poor school performance. They've blamed everything on this disorder in the Northeast. My brother's a veterinarian. He had all kinds of arrhythmias associated with this thing. His daughter contracted and had similar kinds of problems. His son contracted it. He had similar kinds of problems. Barely got into the Coast Guard Academy as a result of this stuff. Antibiotics. The lesions are pretty classic. But I looked for a picture of red central clearing. I could not find one. All of them are just uniformly red. I found no central clearing in any picture I could find. Antiphospholipid syndrome, a non-inflammatory immunologic syndrome. It's in the rheumatologic section. causing blood clots. Antiphospholipid syndrome. This is about antibodies associated with these phospholipids, basically predisposing people to make blood clots all over. Blood clots are in their head, they stroke, they have heart attacks in the coronary arteries, they have DVT, they have PEs. And and most of all, women who get pregnant keep on miscarrying because they get blood clots in their placenta. So they're on warfarin for the rest of their lives. And they can but the problem with being on warfarin for the rest of your life is you can't take it when you're pregnant because warfarin crosses the placenta, number one, and number two, it is a teratogen for children. So they wind up having to go on to some kind of low molecular weight heparin. The catastrophic antiphospholipid syndrome is everything's clotting all at once kind of thing. I don't think I want to, the only thing I want to spend time on here is the DMARDs. You see commercials for this all the time. What's his name? Mickelson, the golfer guy, who does the commercials for psoriatic arthritis. Phil Mickelson. He does that commercial, psoriatic arthritis. It's a DMARDs. DMARDs, disease-modifying anti-rheumatic drugs, are drugs which basically attack the immune system in a narrow area. In this case, we're talking about joints and the skin. But that doesn't mean that the rest of the immune system is left untouched. So these people are prone to getting infections, and they're prone to developing cancers because their immune system is compromised. And it's used in rheumatoid arthritis all the time because basically it staves these joints. So the first treatment in rheumatoid arthritis is generally methotrexate. If that doesn't work or there's an additional drug needed, DMARDs come into play. And these DMARDs stop the destruction of the joints in rheumatoid arthritis. So that's kind of a big deal, and that's why they're the core treatments now in these disorders. DMARDs. Lupus, horrible disease. Every system known to man, this is a self-destructive autoimmune process, generally in young women. But look at every organ there, 9 more total, everything that you can think of is being destroyed by this autoimmune process. Most of the crises that come in to the ER, lupus cerebritis, any kind of seizures or CNS problems or bowel problems, generally they can be handled by giving a slug of steroids. The malar rash, not seen in all, certainly not, and some people with malar rash don't have systemic lupus. Seronegative spondyloarthropathies, these are the arthritises that have rheumatoid negative, and the kind of the hallmark of this one is what we used to call Reiter's syndrome, but it's really now called reactive arthritis, where here urethritis results in conjunctivitis and arthritis. And so how does that work? Urethritis, this infection, then triggers this immunologic problem in the eyes and in the joints? Yeah, and the answer is yes. And there are some commonalities here with other arthritides, like the arthritis is associated with Crohn's disease and ulcerative colitis. The arthritis associated with psoriasis is also in this category as well. And if you'll notice, in this reactive arthritis, we said it was urethritis and then conjunctivitis, could be iritis too. But the fact of the matter is that you don't need it only involving, look at the other causes. It could be cervicitis could be the trigger, chlamydia could be the trigger, dysentery can be the trigger, Campylobacter, all kinds of infection can trigger the development of these other inflammations that are somehow etiologically connected in a very, frankly, complex way. So psoriatic arthritis, inflammatory bowel. And lastly, I think that we went through this a number of times, but I wanted to show you a few pictures. So on the left is erythema marginatum, supposedly. Look at those little bumps on the shins of the elbow and the knees there. there's a nice example of this rash. This is the rash. It does have supposedly central clearing, migrates out and connects with its brother and sister rashes to make a serpentine kind of thing. There's the carditis. It's pericarditis, myocarditis, any kind of heart-related thing. So this could be probably pericarditis, a big sac around the heart. And I think that is it. What time is it? Well, it's 1 o'clock. We're not too far behind. I do want to thank you for persisting. You're going to do fine. Anybody who can stand through this, you got to be able to do fine. It's the only justice that we have. You've earned it. Damn it, you've earned it.